Hello and welcome. My name is Dr. Brian Hill. I'm the director of the Lymphoid Malignancies Program at the Cleveland Clinic, Taussig Cancer Institute. And I'm happy to be joined today by Dr. Jan Berger from MD Anderson Cancer Center. Dr. Berger, could you introduce yourself and tell us about your title and your work?
Yeah. Hello, everybody. I'm Jan Burger. I'm a professor at the Department of Leukemia at MD Anderson Cancer Center. My interest is chronic lymphocytic leukemia, basic research and clinical research. And today we're going to discuss an abstract that I presented at the ASH meeting.
Excellent. Yeah. So the abstract was abstract number 4615. So this is entitled Treatment with First-Line Ibrutinib Improves Overall Survival in Patients with CLL and High-Risk Genomic Features to Rates Approximating an Age-Matched U.S. Population. Pooled analysis of phase 3 trials with 10 years of follow-up. So maybe you could just tell us, maybe set the background for what was known about this topic. Obviously, many patients with CLL are worried at the time of their diagnosis what their longevity looks like. How is this going to impact the rest of their life? And I assume that was sort of the motivation for this study.
Exactly. Yeah. You set the stage perfectly for me to give you a little bit background about this study. We've witnessed over the last 10 years that we shifted from chemotherapy-based treatments to the new novel agents, and many patients are now treated with this group of agents called the BTK or Bruton tyrosine kinase inhibitors. And Ibrutinib is the agent which has been around the longest, and therefore we have from clinical studies very long follow-up, and that's an opportunity now to look with very long follow-up in this particular study, approximately 10 years of follow-up on patients joining studies about 10 years ago and see how their long-term survival is, and to compare that to a matched group of people in the US of the same size, and see is it likely that patients with the CLL on these new treatments are going to die from their disease earlier than the comparator population without leukemia or not. So that is something that we already published last year with a somewhat shorter follow-up for the entire population. And in this abstract, it was focused in on high-risk patients. We call these patients high-risk because historically patients with these abnormalities tend to have shorter survival, especially shorter survival when they received chemotherapy-based treatment. So this was looking at a group of patients of 490 patients from two different studies called Resonate and ECOG trial, and they received either single agent Ibrutinib or Ibrutinib with a few months of CD20 antibody rituximab, and their long-term survival was analyzed. In this abstract, we focused on higher risk patients. Mostly those were patients who are what we call IGHV unmutated, where they have an unmutated B-cell antigen receptor, and those patients usually have more active disease. It also included a large group of patients who have what is called an 11q deletion, where part of chromosome 11 is broken off essentially, and those patients also tend to have more aggressive disease. Oftentimes they're also unmutated. And there's a small cohort of 17p deleted, chromosome 17p deleted, or TP53 mutated patients, but not many because by design, those patients were not usually allowed to enter these studies. So the main take-home message of this analysis is that the survival curves with a long follow-up of 9 to 10 years, had a survival that is superimposable, that is identical to that of the matching population without leukemia. And that's kind of reconfirming what we published last summer for the entire cohort, not focusing on high risk. And I think that's a very positive and good signal, helps us. I think when we meet patients who are newly diagnosed with CLL, that we have now data that with these new agents, many patients can expect to have a normal life expectancy. We cannot guarantee it for everybody, but at least we have now this data set with this very long follow-up indicating that we've made major progress as compared to
certainly, So
things in the past.
When we look at the data, from the abstract, the 9-year overall survival of the general, population of this comparable age, the 9-year survival was 82%, because of course, people die from other things. But the 9-year overall survival in the CLL patients was 81.2%. So basically the same. And for younger patients also, you point out that for patients under 65, the 9-year overall survival rate was 89% for those treated with Ibrutinib, and it was 90.0 for those sort of age-matched controls. So really, I would say from a statistical difference, no difference there. And as you call it, sort of superimposable. What did previous studies show in the chemotherapy era for if you compared the general population of patients with CLL? I know many patients will look at old websites and say, that the survival with these high-risk features is only a few years. Do you recall any studies that sort of pointed that out, and are those relevant anymore?
Well, the shift from chemotherapy-based treatment to these novel agents, that's based on randomized studies where half the patients were treated with our traditional chemotherapy versus mostly BTK inhibitors, but later also venetoclax-based treatment. And in those studies, we had, in all studies, a major improvement in PFS benefit, and in some studies, overall survival benefits. So that was driving this major shift. But if you look historically at survival data, especially from high-risk patients, then we found, if we look at the extreme, the 17p deleted patients, that most patients had a very short progression-free survival with chemotherapy-based treatment, usually just 1 to 2 years, and overall survival after 5 years was usually not more than maybe 20 to 30%. So many patients were receiving treatments, but the disease within just a few years oftentimes resulted in patients passing away from their CLL in the chemotherapy era. So I think that speaks to how much benefit we are now seeing with the novel agents.
For sure. I think, there have been some population-based studies also. This is looking at specifically clinical trial eligible patients, but even in those patients treated outside of studies, if you look at large populations, we've seen just a continued shift upward in the survival. And I think, we all see this in our clinics as practicing oncologists treating CLL. We have many patients who've been on the BTK inhibitors for years and years and years and are just doing well, and going into their 70s and 80s and beyond. So I think these data are really excellent to kind of confirm what we've been suspecting, and it's really a nice sort of precise way to demonstrate that even for the high-risk patients, they can expect really longevity, basically similar to the general population. I think it's a nice sort of demonstration of the improvement that we're seeing in all of our patients as we've shifted to targeted therapies. Are there any kind of next steps or future directions that you see that in the field that
Yeah, that's a
this
good
kind of
point.
might
Maybe
help
one
our...
additional thing that was briefly also mentioned in this abstract is that they looked that we looked in our analysis at how patients are doing when they take these inhibitors long term. Many patients are struggling with side effects, and that is the problem that we're currently facing, seeing patients being on a BTK inhibitor for many years, having cardiovascular side effects, for example, and we analyzed, is there any benefit from dose reduction in long-term treatment of these patients? And that was not a larger cohort, but within those approximately 50 or 60 patients who had dose reductions within these studies, there was not any negative effect seen in terms of survival if somebody was dose reduced, but it addressed the concern of side effects. It helped to mitigate or reduce or abolish side effects. And that's maybe one of the directions for the future if we want to continue using long-term BTK inhibitor therapy. It could be more systematically analyzed if maybe in the long run, the initial higher dose could be reduced with maybe the first, second generation BTK inhibitors to allow for reducing side effects. There's a study that's currently being done with Ibrutinib, where patients are randomized to receive either 420 milligrams of Ibrutinib alone or in combination with venetoclax versus a reduced dose of 280 milligrams. And that may in a few years tell us if that's something that's a strategy in the long run. For any patients that I treat outside of a clinical study, I tend to reduce, when I use Ibrutinib, long-term patients on Ibrutinib, I tend to reduce the dose even with small side effects. And that has, in my opinion, been a good strategy to hopefully avoid some of these long-term side effects.
Yeah. So certainly with the acalabrutinib and zanubrutinib being more frequently prescribed as frontline therapy, we would probably, expect that, again, survival is going to be the same, but probably side effects and quality of life may be better. Anything else kind of going forward in the future? One of the things, of course, we want to achieve is long survival, and we think we've gotten there with this approach. But even in the best of scenario, if you're not having side effects from a BTK inhibitor, if you're taking it, for years and years, there is a significant cost. And then there's, of course, some bleeding risk that really never goes away. So what do you see in the future in terms of sort of time-limited frontline therapies as options to kind of get people on drug holidays and still achieve this excellent overall survival?
My observation is that in particular, younger patients who are still active, working, tend to prefer time-limited treatment. They like the idea of being on a treatment for 1 or 2 years and then have a break and get back on treatment maybe many years later. And that's a field that has evolved over the last few years and is becoming increasingly, I think, attractive to our patients right now. The approved one would be venetoclax obinutuzumab, but there may be approval this year of acalabrutinib with venetoclax, and especially for younger patients, but also for older patients, that could be a good alternative. The only hesitation sometimes is, well, if you combine 2 agents, you have a potential to have a bit more side effects, especially around myelotoxicity. You also have with the venetoclax this necessity initially to monitor for tumor lysis. But I think moving forward, this is going to be, for many patients, a great alternative. Their concern, hesitation in the beginning has been to say, well, if we treat for a certain limited time and then we let the disease in a way come back a few years later, there might be more aggressive disease. There might be what we call clonal evolution, where the disease comes back more aggressively, because that's what we've seen in the past with FCR, for example, chemotherapy-based treatment. But the data that we have is, if somebody has disease coming back after these time-limited treatments, there does not seem to be an enrichment of resistance mutations. It doesn't look like the disease comes back more aggressive and responds well to treatment with the same type of agents. For that reason, I think this has very good future, these combination treatments that are given for something between 1 and 2 years.
Excellent. Well, that was great. I hope that the audience found this very useful, and I think very encouraging. So I think we can probably conclude, and thank you for your time and efforts on this.
Yeah, thank you.
All right, great to see you.
Likewise.
Okay. All right,
Have a good
take
one.
care. All right, bye-bye.
Bye-bye.